In this next panel, we will be focused on how to really improve performance in clinical practice. In the context of a diverse population. And for those of you who don't follow medicine and medical politics much, the issue of how to calculate how kidney function works in the individual and how that may vary as a result of placing that individual in a particular ethnic or racial box might actually help or not their care. There was a huge controversy around it, and I'm pleased to say that we have a truly diverse panel that were extremely active in what I regard as a very positive synthesis of the various views in ways that really ultimately just benefit us, the patients. So we have today a panel of 3, and as the song goes, 2 out of 3 ain't bad. 2 of the panelists are in person here, and 1 is remote. And those are from the University of Pennsylvania, Dr. Nwamaka, Eneanya, Dr. Arjun, aka Raj Manrai, and Dr. Powe. So I will take the lazy way out, which I've actually directed all moderators to do, have the panelists introduce themselves and have their remarks going from there. So I'm going to cede the podium to Dr. Ananya.
Thank you so much, Dr. Kohane, and to Dr. Manrai for the invitation to speak at this very important conference. As you mentioned, I am at the University of Pennsylvania, and typically when I give a talk, I usually give my small financial disclosures, a very short list of consulting opportunities. But in particular for this topic where we're focused on race and precision medicine, I want to actually give some life disclosures. So right now, I'm an assistant professor of medicine and epidemiology at Penn Medicine. I'm an NIH-funded researcher whose career has really focused on treatment decision-making and health equity among elderly and frail patients with advanced kidney disease, in particular thinking about the harms and benefits of dialysis. So why am I here? Well, my life disclosures is that I'm a first-generation Nigerian American. I have kidney disease that runs rampantly through my family. And in the first few talks, we talked about genetics and the effects of ancestry on disease risk. I myself have been genotyped for APOL1, which is a known risk factor, at least high risk factor for developing chronic kidney disease with rapid progression to kidney failure. My next disclosure is that I studied Black sociology in undergraduate as an undergraduate student at Cornell University. And so the thought of race being a socio-political construct has been really ingrained into me since I was a teenager. And then next, I attended Meharry Medical College, a historically Black medical college and university, the actual first HBCU medical school in the South to train Black physicians when they were denied entry at that time. And so that brings me to me being a health equity researcher and having that type of lens and a nephrologist who's delivered care, diagnosed and managed thousands of Black patients with kidney disease, and how have I integrated that care into their disease process and bringing that health equity lens to their care. And so With that being said, and speaking about patients, I think it's very important that there's a few lessons that have been learned, and that's one, that we have not been transparent as a medical community in terms of how we use race to diagnose and manage kidney disease. Now, I told you that my research has really steeped in decision-making for patients with kidney disease, and one of the central principles of decision-making is transparency. Shared decision-making is transparency, and we have not done that. So as a nephrologist on the panel, let me summarize very briefly how we got to this point of using Black race specifically to diagnose and manage kidney disease. So I'll try to make it simple because I'm a nerdy nephrologist and I do love the kidneys, but I'll tell you that they're very complicated organs. And to actually measure how well the kidneys are filtering blood and removing excessive waste and fluid from the body is very difficult. And so 2 decades ago, researchers led by Dr. Andrew Levy, who was at Tufts Medical Center, developed this eGFR equation to really help assess a snap decision at the bedside about how well a person's kidneys were functioning. And so they used an endogenous biomarker that we all have in our bodies, creatinine, coupled with an exogenous biomarker, iothalamate, which is our gold standard for measuring kidney function. And what they found in this 1999 landmark study, the first eGFR equation to be developed, was that when they compared Black patients who were separated actually from all of the other patients, all of the other racial groups, that Black patients, when you looked at their measured GFR, at the same measured GFR using iothalamate, their endogenous biomarker, creatinine, was slightly higher than the other racial groups. And so that introduced this Black race coefficient to account for that difference that they found in creatinine between Black and non-Black participants. Now, we can argue that this was a very monumental study for the field of nephrology. Here we are with this very rigorously developed tool to assess a patient's kidney function very accurately at the bedside. However, this is the lesson that we've learned, is that we stopped with race. We just said, Black people are different from every other racial group, and it's likely because they have greater muscle mass. We know that muscle mass actually affects all of our creatinine levels in our bodies. And that is one of the lessons that I think that we should learn going forward, is that you just can't stop with race. We know for a fact that there's things that affect creatinine. There's medications, there's kidney disease, there's muscle mass, as I've discussed, and none of these things were assessed. There's actually also some genetic biomarkers that affect creatinine. None of these things were assessed in these original studies that were assessing a biological outcome. And this is the lesson that we have to learn when we're using race in any of these clinical algorithms. So that's the first lesson. The next lesson is, again, the transparency with our patients. So I was lucky enough to be featured on a nationally syndicated show, the Doctors TV show, where they featured this controversy of using race to lead clinical care. And in that show, 2 patients shared their personal journeys of being listed for transplant much later than they desired, or having to be charged more money because eGFR was confusing the insurance company, for instance. And it was really heartfelt stories and powerful stories that led me to believe that patients felt very betrayed that we were using this behind their back. And even when they did discover that it was being used, there was so much red tape because no one had ever really questioned it the way that we're questioning it now. And so having patients not only be aware of what we're doing, but actually be at the table, as we heard earlier in a lot of our discussions, developing these research tools is incredibly important. And then I'll close with this last lesson that, in this controversy, I've seen a lot of unnecessary division. And what I've also learned, having a sociology background, is that biomedical science is not the only science. There's been sociological science that has looked at this very aspect of health inequities, in particular among marginalized communities, for centuries. We heard about Dr. Du Bois, who studied Black Philadelphians and looked at social inequalities and how that impacted health inequalities in 1899. And so this has been going on for a long time, and there seems to be a divide between the biomedical community and the sociological community, when we know that there have been social scientists, people like Dorothy Roberts, who have studied this for decades, and bringing them to the table as we think about the path forward is incredibly important. So I'll stop there. Thank you.
So I think Dr. Ananya stated that very, very well, and I agree wholeheartedly with those comments and the conclusions, particularly around the need for diversity of voices. So I'll just introduce myself briefly and then give my perspective on how I've seen this evolve over the past few years, and I think the role that data has played in guiding our decision making for the past couple of years on how to move beyond race and how to shed those problematic labels. So I'm Arjun Manrai. I'm an assistant professor in the Computational Health Informatics program at Boston Children's Hospital and at the Department of Biomedical Informatics at Harvard Medical School. And I direct a research lab that works broadly on developing machine learning and statistical methods for improving clinical decision-making. We have a very long-standing interest in using computation to improve care across populations. And so we're fortunate in that capacity to work in very close collaboration with a number of clinicians and also to work on a number of different clinical topics, including the subject of this panel, which is how the use of race is evolving in current medical equations in real time, and in particular for the estimated glomerular filtration rate, or EGFR. So I think Dr. Ananya did a wonderful, perfect job of summarizing, how we got here and why the coefficient, or why the correction term was introduced. So I won't rehash that, but maybe I'll just talk about a couple of lessons that I think we've learned in my group and we've learned as a result of working with a number of different folks over the past couple of years. So first, I'd say, and I think again this echoes the previous comments, beware of false dilemmas. So I have a 2-year-old and a 4-year-old at home, and so I have to hone my negotiating skills constantly. And so if I present my 4-year-old with an option of, would you like an apple or a banana for a snack? She'll very quickly point out to me, Daddy, I think we could go to the pantry and get some chips. And we're confronted with a lot of false dilemmas. I think with EGFR, there was a false dilemma that was embedded into our collective consciousness that we either use race or we are inaccurate. And I think this was this was often made concrete with the presentation of, 1 or 2 equations as options, but in reality, there are an infinite number of ways to remove race from the equation. I think it's crucial to understand the strengths and weaknesses of the different approaches, of the different ways of removing race. We published a paper in the New England Journal of Medicine where we compared a number of different approaches in terms of accuracy, representativeness, availability, and other ways for policymakers to decide on the best path forward. Markers like cystatin C is just one example, are race-free and have been validated, not always featured in, especially in the early conversation, as a potential path forward. I think it's crucial that as we're improving the equations, we not get trapped into false choices, and we realize that a lot of the bias comes from just the way that we pose the initial trade-off or the initial question. So second, I'd say our intuition often fails, and we need representative data to make informed decisions. Related to that, we need to separate probabilities and utilities. So in some sense, I think this is obvious, but I think when you go to perform a study, there's a lot of not so obvious things. So what is the representative data? Who's represented? Who's not represented? What is an acceptable performance decrease before rolling out a new equation? What's a required, minimal level of performance? What's a significant difference between 2 models that we're weighing between, or 2 equations? I think they're very hard questions to answer in a compelling way for everyone. And I think part of the reason is that we're often conflating the probabilities or the risk estimates that are implied by different equations or different approaches and the utilities. So for the probabilities, just to give one example where I think intuition may fail and where data is crucial, the race correction term, the coefficient for in the CKD epi equation is 1.16. And so this may seem like a modest multiplier, but depending on how the equation is altered, this can have significant implications. So as an example, we published a paper in JAMA where we used nationally representative data to estimate that this would result in a 3.5% increase increase in the overall prevalence of chronic kidney disease among Black adults in the United States. So projected nationally, that's 1 million new CKD diagnoses across the United States. There are other downstream changes that may result depending on how the equation is altered, including increased access to specialist care and kidney transplantation, as well as reclassifications to more advanced stages of chronic kidney disease and associated drug contraindications. So third, and I think this relates to the utility side of the decision analysis, I think the way in which a real diversity of voices has shaped this debate is very, very powerful, and we can't spend enough time talking about it. So it's amazing, I think, to see how medical students nationwide have really made their voice heard, how nephrologists like Dr. Ananya and physicians like Dr. Powe, who's about to speak, have guided the community. And I really think, how there was a task force that was formed that really explicitly from the get-go included very different perspectives, and many, many perspectives will be a model that I suspect will copy in many other areas of medicine. So this was a task force that was formed by the National Kidney Foundation and the American Society of Nephrology to address exactly this issue around how race is used. I think we're also witnessing a new type of computationally enabled medical student really have influence very early. So I'm lucky to have such a student in my own group, James Diao, who's first author of the New England Journal and JAMA papers that I mentioned. So James is formally trained in statistics and computer science before medical school, and I think it's his ability to sort of keep these ideas truly together simultaneously that's led to impactful work on this debate very early on. So maybe I'll stop there, and I'll turn it over to Dr. Powe.
Well, thank you, Raj, and thank you, Zach and Raj, for inviting me. Hello, everyone. Good afternoon from San Francisco. I'm Neil Powe. I am Chief of Medicine at San Francisco's Safety Net Healthcare Institution, the Zuckerberg San Francisco General Hospital. And I'm also a professor of medicine at the University of California, San Francisco. I'm a general internist, and I've had a long-standing interest in health equity and disparities in care. In fact, much of my work has been done in kidney disease. And I am just delighted that you are having this symposium. It's great to see Harvard lead in this area. When I was a medical student at HMS, there was no curriculum on race, except for some amazing sessions on racism that I had in Alvin Poussant's class. And that was enormously useful. Nobody talked about race. It was kind of something you shouldn't talk about. So this is great to expose this and have this open air symposium. As Raj said, I'm co-chair of the NKF ASN Task Force in Reassessing Race and Kidney Function. I want to make it crystal clear, though, that my comments today are my own, and they do not represent those of the task force and should not be construed as such. So let me just offer a few things building on what Dr. Ananya said. We do need to have transparency. I don't think patients have been aware of their race being used in clinical practice. And that's why we insisted that patients be on the NKF ASN task force, and why we held an open forum for patients to express their views. We've seen the growth of my chart and open notes, which is a great step forward. But we know that even with that access, only 6 to 10% of patients actually use that access. Maybe that's because we use so much technical jargon that's not understandable to them or bores them. But I would say this, that even more concerning than writing patient race in the medical record is clinicians looking at a patient and treating them on the basis of their skin color or other physical and visible characteristics. That's what George Floyd taught us. It wasn't a card in his wallet with the race. It was someone making assumptions about their motivations or desires or their values. So if we want to get rid of bias, explicit or implicit, we have to go deeper in examining physicians' biases, our own biases, than just using race in clinical algorithms. That's where our emphasis should be. And, it's time to recalibrate the use of race in society and medicine. That's what this whole debate over the last year has told us. The imperfections of race as a tool. But I will say this, that passion alone cannot drive medical practice. We can't let blind enthusiasm drive the practice of medicine, just as we cannot let the political views drive the care of patients. COVID is a good example of that, of how political views are driving prevention implementation. And so we had myths about why and how race-based algorithms were propagated. And students, the public, and clinicians began to believe those myths as if social media was the authoritative source. And our interim report of the task force laid out the evidence as a means of educating folks about kidney function measurement as well as health disparities. I hope that a thoughtful approach might be taken in other fields, as we have seen the use of race in algorithms is not desirable. So physicians have an obligation to use evidence-based thinking they learned in medical school to inform, to counsel, and treat patients, not create their own version of medicine. And that's why evidence is so important, as well as transparency. And what we need to do is to collect data on the full range of biological, behavioral, and social determinants of health, as Dr. Ananya alluded to. Biological, behavioral, and social scientists have developed their own theories in isolation of the scientists in other fields. And I would say computational scientists are not immune from that either. We want to understand what is driving the truth. As Dr. Ananya said, that African Americans have a higher serum creatinine than whites across every age and sex group at the same level of EGFR. That's real. And it's demonstrated over and over again in different populations. But what's driving it? Is it social? Is it behavioral? Is it biological? What if we understood that and that was the basis of our starting point? So I'll end there, I think we'll move on, I guess, to discussion or questions.
Thank you to the panelists. And before I stoke questions, I'm wondering, is there any particular reactions that any of the panelists want to say to any of the points made so far?
I'll just chime in briefly and say that I'm honored to serve on the ASN NKF task force with Dr. Powe, and that my comments are also a reflection of my thoughts and not a reflection of the task force.
Thank you very much. Wow, these are very apparently politically sensitive times for those kinds of disclaimers to be had. So, all good. Forgive me for any faults. It's like right before Yom Kippur, so certainly forgive me for any sins I have made in public or private. So I actually have a question that I didn't quite prepare our panel for, but I'll ask it anyway. From my perspective, the nephrological society's efforts have been quite successful. I would like to hear the perspective, perhaps starting with Dr. Powe. What were the key ingredients for that success? You're muted. The famous phrase of COVID.
Thank you very much. I think the key ingredients were bringing together, as I alluded to, stakeholders with different perspectives to really hear and listen to each other and learn from each other from those perspectives about, what race means, how it's used as a tool, and how it can have an impact when it's used. And so I would start with that, you know, hearing from a broad range of stakeholders with different perspectives so that we could craft a solution that brings us all together, and uses the collective wisdom that people from different disciplines bring to the table.
Thank you. Dr. Eneanya.
I would echo, I would build upon that and say, not only were we, inclusive of a diverse range of thoughts and scholarship, but I really credit the medical students in the younger population for really pushing this forward. It started actually here at Harvard Medical School with a group of medical students who were doing their elective at Beth Israel Deaconess. And they got rid of race in their EGFR reporting in 2017. So 4 years ago, this occurred because of medical students who refused to accept the I don't know. So when they were rotating on their clinical rotations and people were telling them to use the Black race coefficient, the question was why? And, you know, the professors and the pathophysiologists who were teaching them at the time said, I don't know, this is just how we do it. Black people have more muscle mass than every other racial group. And they went and they did a large anthropological review of how much of a fallacy that notion is of Black race. Just having Black skin makes you more muscular than every other racial group. And it was with that knowledge and that advocacy that medical students have across the country push for change and challenge their leaders. And that's the whole purpose of medicine and science, right, is lifelong learning. And that's exactly what these students did. And so I think it's really inspiring that this has been in practice for several decades. You know, I wrote about it in JAMA first in 2019, but it was really medical students in 2017 that pushed for change locally, and that just spread like wildfire. I also say that having some political involvement, so the Ways and Means Committee of Congress, the legislative writing body, also got involved, and I think that really helped push the needle. I myself have been contacted by Elizabeth Warren, several other political leaders about bills that are being written to make sure that this doesn't happen again when we're developing devices and algorithms. So I think the combination of all of these things is what's helped push the field forward.
Professor Manrai.
So I completely agree. I think Dr. Ananya's point about medical students having a really powerful role at many stages of this conversation over the past couple of years is absolutely true from my perspective. I think the task force from the National Kidney Foundation and American Society of Nephrology also did a good job of getting buy-in by being transparent in their proceedings and being transparent about their timeline as things evolved, and releasing things like interim documents that gave us a taste of where this is going. And so I guess as also a disclosure, I'm not on the committee, but I did brief the task force last December. That's public knowledge, and I think that. Dr. Ananya also wrote a very, very influential piece in JAMA, I think was it 2018? 2019, that I think, I discussed with many colleagues who their minds were changed after reading that paper and learning about just reconsidering, why we do this, why this is this way. And when you quickly get to, if you start going down this path of this paper cites this paper, cites this paper, you get back to some dubious claims from the 70s and the 80s that are underpinning a lot of this edifice. I think it starts to crumble, and I think that changed quite a few minds in our hospitals and in our nephrology practices.
Thank you. More questions I did not prepare you for.
May I say something?
Oh, please.
Yeah.
Well, I'll teach you not to show up. Go ahead.
I just want to make it clear that people understand the history and the evolution of science. And I want to take you back to 1976 when the so-called Krakow-Gault equation was developed. that I learned at Harvard Medical School. And that equation was developed in 249 white men. And then it was extrapolated to every ethnic group and to women as well. And, you know, as Dr. Ananya said, in the late 90s, Andrew Levy and colleagues, what they did is in the modification of diet and renal disease study, were able to recruit a more diverse cohort that had a large number of African Americans in it. Their intention was to be inclusive in science by recruiting a diverse ethnic group. And when they saw a signal, they just felt that they could not ignore that signal. I also want to make it clear that, you know, I've studied disparities in transplantation for years. And in the 1980s, a fellow named Paul Eggers in the government wrote articles describing data in the Medicare system about African Americans and other minorities not having access to the transplant wait list. And it was profound. And that was before these equations with race were instituted. I worked with a fellow, actually a former HMS medical student named Craig Kinchin, and we did a study in the mid-1990s on nephrology referral and showed that African Americans were less likely to receive nephrology referral than whites. That was done, and those patients were recruited before the equations were in widespread clinical practice. So there's been a misnomer that actually these equations cause these disparities. Could they aggravate them? Certainly, but they did not cause them. I also want to speak to what Dr. Ananya said about the Beth Israel in Boston. They were a leader. And Dr. Melanie Honig really led a very thoughtful group at the Beth Israel with equipoise. And what they didn't do, they didn't come up with a value of normalizing blacks to non-blacks. And what I've seen in terms of just dropping the race coefficient, which is really easy to do in the computers. It's just easy work. That, when you do that, I really think that is ethnic cleansing of the data, because you're dropping the data on an ethnic group. And that just doesn't, it has never sat well with me, this kind of normalizing. But finding a path forward to not include race that has that equipoise, I think, is really, really important. So I just wanted to make those clarifying remarks.
So before I go on to my next question, does anybody want to make any comments at this point? No. All right. So here's my question. I actually don't know the details of what this panel, that two of our panelists, of what the society's recommendations that two of our panelists participated in is going to say. But it could be, I don't know if it's a fact, that it's going to recommend certain measurements to be made in blood or in urine to individually adjust the estimate of kidney function for the individual. And I'm now going to ask this question in the context of what I think is going to happen in many other biomarkers for cancer susceptibility, biomarkers for pulmonary function, biomarkers for Alzheimer's susceptibility, or biomarkers for traumatic brain injury. These require additional measures. And the part about medical students rings true, not that I was questioning that it was untrue, but rings true, because those of us who've been in medicine know how inertia-driven the medical system is, and that we are told things, and we already know that, because we're told by our elders, that 20 years from now, half of what we are told is going to be false. You just can't tell us which half is false. So given that inertia, it's very hard for most of us to say, oh yeah, let's do this other thing. Let's measure this other thing so we can come up with a better individualized therapy. So specifically, without disclosing what the recommendations are, how do you see the funding? It seems like I'm asking the capitalist Marxist question every session, but how do you see the funding for these additional things that have to be measured? Where is it going to come from? Is it going to come out of the hide of the rich but crying poor healthcare system, government, individual, third-party payers? I'd be curious where you think that's going to come from. I will now, with apologies, remember, I'm atoning for all my sins before Yom Kippur. Dr. Powe.
Okay, yeah. We've known for years, it takes years for science to be implemented in medical practice. Indeed, it took 15 years for the MDRD first equation to be adopted by institutions and laboratories across the country. It takes a lot of time. And there are a lot of barriers to that. It's not only the economic issues, but inertia, the beliefs in the data that underlie it. So a variety of things, lead to hesitancy by both physicians and our healthcare system to adopt new innovation. That's an area that I studied a lot when I started my scientific career. I would say this though, it gets to what is the price of a human life, and what is the price of a good quality of life, and how much are we willing to pay as Americans? And do we want to pay a price for health equity? I think that the voices we've heard elevating health equity to a new level should say that there should be more funding to achieve health equity. And I hope that is true. I hope this is just, not kind of virtue signaling, but has more to do with putting our money where our mouth is. And I'm hoping that the community, and that includes our payers, the government, whatever the recommendation is ready to address those barriers to implement a raceless solution.
Dr. Eneanya, would it discomfort you to answer that question?
Would it be?
Would discomfort you to answer that question?
No, not at all. I think that, there's going to have to be a multi-pronged approach. We heard in the last panel that there's upstream interventions and then there's downstream interventions. And I think, what we need to be clear about is that it's not race driving inequities, right? It's racism, whether that be structural racism, whether that be interpersonal racism. And so, where is the money coming from in terms of the upstream interventions? I mean, Humana, I don't know if people saw the announcement this past week or in the last week that they're committing $25 million to affordable housing in a number of states in the United States to address the health inequities that are directly associated with housing insecurity. So that's one sector, the private sector. And as Dr. Powe said, I think the government sector, philanthropists, I think all of these efforts are necessary to really push for change. And then downstream, we're thinking about biomarkers, like Dr. Manrai mentioned, like cystatin C, that we have not seen, that is another, endogenous biomarker, like creatinine that we all have in our bodies, that actually hasn't been shown to perform significantly differently across racial groups. So if we're going to advocate for things like that, currently creatinine is used significantly more than cystatin C, and cystatin C is not available widely. So we need companies, the private companies that own these cystatin C assays to make it cheaper. Right now, it's significantly more expensive to run cystatin C. It doesn't take very long, but since the assay is not used widely across the country, it's significantly more expensive to run that test compared to creatinine. So we need advocacy, and we need private sector companies that are in charge of these laboratory billing and pricing
asking to be on board to really push for health equity downstream when we're thinking about biomarkers.
Thank you. Professor Manrai?
Yeah, so I think those are great points. I think Dr. Powe made a point about the diffusion of innovation and how slow it can be between where there's recommended practice guidelines and we actually see adoption in practice. And I think this is, it's a really key point. And so Dr. Ananya will correct me if I'm wrong, but I think the MDRD equation, which is, for quite some time is no longer the most up-to-date recommended equation before the report comes out, is still used by the majority of reporting laboratories. And so I think, even before this, in many ways, lightning quick change to how race is operationalized, how race is used, that we saw over the past couple of years, and that we're going to see formal guidance around. Even the current guidance is not followed by many labs. So I think it's a very complicated system. I think making projections around the cost of course, I strongly agree that we need a multi-pronged approach, and that we're seeing investment into upstream determinants of health and inequities that Dr. Powe referenced, that have been around for many decades, that we've known about for many decades. I think I'll also exercise my prerogative as not being a member of that task force, so I think that'll give me some chance to speculate a little bit freely on what we might see come out in that report, without making too strong of a prediction, which is a little bit weak. I will say that there are likely orders of magnitude differences in the potential solutions that are recommendable. So some are change the coefficients. Some are, I think we mentioned that one of the dominant approach last year was to drop the correction term. Arguably, that's the easiest thing to do to drop the note in the healthcare IT sort of workflow. Others that are, I think, unlikely to be recommended right now, if I were to guess, but maybe in the foreseeable future, are new low molecular weight biomarkers and metabolites. But I think those get to your point, Zach, of being more expensive things that we're going to have to figure out how to pay for if we want to remove race in that path. But there are orders of magnitude differences even amongst the current options. So again, let's not get trapped into thinking that it's necessarily going to be a very expensive option to move beyond race relatively quickly. So again, I don't know what it's going to look like, but it's worth understanding that there are many different options that I think that are under evaluation.
So I will use my prerogative of being at the podium to actually make the following comment. This is the 7th annual Precision Medicine Conference. Most of what our conferences have been about is the shiny future of genomically informed medicine. And you will have heard many impassioned arguments for molecular biomarkers, which are only weakly informative for a number of diseases that cost thousands of dollars. Yet, much of the audience that you'll hear there, or that you heard in past years, are incredibly supportive of it. And I'm just wondering, what are the politics that to align, let's say, a cystatin C assay, even if it's at a current price? I'm sure to use, I love Neil Powe's framework. I'm totally with you, Neil, on essentially, we need to start standardizing on essentially the moral equivalent of quality adjusted life years, so that we know that we're treating all lives equally and all different outcomes, that we're doing the same investment, let's say, for cancer lives as we are for heart disease lives. And so I'm sure if you did that calculation for some of these molecular markers, for some of these precision medicine applications we described in the previous years, they're much more expensive per quality adjusted life year than cystatin C. And so I think that the politics of that and the framing of lives saved is going to be just as important, in my opinion, as the other aspects of this. So we are now getting to the remaining 14 minutes. We're about to go to ask to see if there's audience questions, which I know for a fact that there are audience questions. But before the external audience questions, are there any questions that you'd like to pose any of these amazing panelists while you're here in the room? Anybody wishes to ask a question? Yeah, please step up to the mic. And the protocol is identify yourself and then ask the question.
Wonderful. Can you hear me? Yes. Hi, my name is Ariel. I'm a student in the Department of Biomedical Informatics. Thank you so much for sharing your work and for the truth that you seek in looking to not just use race, but go beyond and try to find the drivers of these biological functions. I have a question because the perspectives here are from health systems representing Philadelphia, Boston, and San Francisco. So it's two related questions. On this task force, were there members representing parts of the country who aren't, I guess, in locations where they're serving people on maybe the blue side of the political spectrum? And then second, do you see a common willingness to look for this truth across the country in the medical practice? Or is it like, are you facing pushback from physicians across the country, or are all physicians kind of in line on this? Thank you.
Yeah, I can start. So the task force, it does have geographically representative representation, I should say. And again, as Dr. Powe said, it's also based on contents of expertise. So we had health equity researchers, we had people who work at the CDC, we had patients, and then we had a variety of scientific presentations over the last year where we heard from across not only the country, but across the globe, different areas of expertise when it pertains to this topic. So yes, to answer your first question. The second question, has there been resistance? Absolutely. And I think that it's largely because race, as we've heard before in some of the previous talks, is an uncomfortable topic, especially for people who have not done the work, right? They haven't read some of the texts that have been referenced. They haven't really delved into it. There's really no reason for them to do it if they haven't done work that needs to include health equity. And so there has been resistance because it's not something that's been routinely taught until the last few months to years, that this is the way that we should be looking at race. We should be thinking about it as a socio-political construct. That's not how it was taught up until recently. And so to tell someone who's in their 70s that this is wrong is, it's not easy to have somebody receive that. So I think that it's been controversial for that reason, that there's been a variety of knowledge on this topic, and that race is also highly politicized. And so it's very uncomfortable. We see that not only in medicine, but in other disciplines, politics, you name it. And so it's been interesting, to say the least.
Dr. Powe or Professor Manrai, feel free to.
I'd be happy to just build upon what Dr. Nina said. There are differences. When the task force was formed, it was done quickly. Both of the societies, the National Kidney Foundation and the American Society of Nephrology, appointed their different members who they thought were experts and could weigh in on the panel. Not even the chairs didn't really were not involved in it, only to suggest content areas of expertise. And Dr. Nina is right that they tried to be broad and pick individuals from across the United States, but it wasn't constructed like the U.S. Congress is. But to counter that, what we tried to do, knowing exactly what the questioner said, that there are different views across the United States, we had over 100 people testify, and even more in the forums that we held of patients, of medical students and trainees, and then of physicians from across the United States. even our panel presentation and experts were over 100 people who came from 21 different states of the United States. And the panels, the open forums were even more diverse in terms of representation. But I think the important point here is, what do these divergence of opinions mean when different healthcare institutions are unstandardizing care? So, right now, I think in Boston and San Francisco, if a patient goes to one hospital, they have a different kidney function measurement than if they went down the street to another hospital. So in one system, they may have kidney disease, in another, they may not. That's chaos. And why we need a concerted unification of the different opinions that are out there, because this is hurting patients. It's really hurting patients. Another point, I think, that goes back to Dr. Kohane's point is that 15% of people in this country have chronic kidney disease. What does that mean? 85% don't. But most of the tests that we use to measure kidney function that are incorporated into what the basic metabolic panel are done largely on the patients that don't have kidney function. So that's a lot of tests. 85% of Americans who are tested who don't have a kidney problem at all, but we got to find out whether they do. So how do you apply the right test in that way, when you think about the population? And what we're really trying to do with this is about kidney disease and how these equations affect not only access to care, but also decisions about what medications to give people, because the kidney is the, next to the liver, the major organ by which drugs are excreted from the body to determine serum concentrations. So there's a lot at stake here, a lot at stake. And as the question said, we need to bring everyone together. That's why we tried to have an inclusive process.
Maybe I'll just quickly add on to that. I think for the second question, I think both Dr. Powe and Dr. Ananya answered the first question very well. For the second question, just to add on to their comments, I think part of the controversy, and as we think about how this might play out in other areas of medicine outside of kidney function, it's my strong belief is not only the point that Dr. Powe is making, which is absolutely correct, that standardization is a goal, and that there can be a lot of confusion if Medical Center A and down the street Medical Center B have fundamentally different approaches to this. But early on, we didn't have data about the potential implications of different approaches to adjusting the equations and to removing race. And so I think it's widely recognized, and I think it's being recognized even earlier in the comparative points on the timelines of reconsideration of race and in other areas for other organ systems, that data is needed very early on for policymakers and for this diverse group of stakeholders to decide on the way forward that achieves the goals that we were setting out for and minimizes potential unintended consequences of some of the approaches to eliminating race.
Thank you. Last call for questions in the current audience. If you have a question, please step up to the mic. And it looks like we have a taker. Identify yourself.
Hi, everyone. My name is Morgan. I'm a first-year student in the Bioinformatics and Integrative Genomics program at HMS. And one of the questions that I've been thinking about over the course of this conversation has been sort of what the impact of interpretability of models is on this problem. It sounds like I'm not familiar with the equation that you guys have been talking about, but sometimes there's this sort of balance that you need to have between, interpretability of a model and, how much accuracy or the evaluation metric that you're using is getting. And I was just wondering if you guys could talk to, how those two ideas come into play.
Yeah, so I think it's a great question. I think it's also a very good setup for our next panel, which is on machine learning and medicine and bias there. Just to quickly address it for EGFR, it's actually very interpretable. Unlike many machine learning models that you'll see in medicine, the coefficient that we're talking about is a multiplier, and so it's in two different popular equations, the MDRD equation and the CKD-EPI equation. And if the individual is African American, then there's a multiplier given the same serum creatinine and other demographic characteristics for what their estimated GFR is. So in this instance, I'd say it's actually very interpretable what your race does to your EGFR. And the debate has been about the problems with that formulation and how to move to a race-free approach. I think there's a whole other can of worms when we can't see how race is potentially operationalized in our machine learning model or in our more sophisticated model, and I think we're going to discuss that probably quite a bit on the third panel.
Dr. Ananya, we want to comment on that?
Yeah, I would say that that's been the core issue, as you're saying, is how race is used. And I'll just give you an example just to let you know clinically how this can be interpreted. So I had a patient who has advanced kidney disease, who's on the transplant list, come to me. She phenotypically is Black, and she identifies as a Black woman, but she's actually biracial. So she has one Black parent and one white parent. And because she's actually pretty well informed and has been following this controversy from the beginning, she reached out to me to get my thoughts. And what she did actually on her own accord was to ask her doctor, can I use my white side to get on the transplant list earlier? Because again, the multiplier assumes that Black people have better kidney function than every other racial group. And her doctor allowed her to be listed. So that should just tell you how inaccurate race is, right? I mean, we're learning now with the tests like 23andMe that people are actually very surprised about their ancestral and racial composition. And so we're using a very inaccurate measure such as race to inform clinical processes. And so although the equation, when you put race in, improved accuracy statistically, just think about how we're operationalizing that in real practice, and that should give you a sense.
So I'll let Dr. Powe answer that question also, but I can't help myself. But note that in case of transparency, your question is excellent, because I'm reminded that the doctor of the mother of Professor Manrai was actually trying to be culturally and racially sensitive to estimate her kidney function. And so what he did, he said that since she was brown, her kidney function probably was going to be an average between white and Black. So he literally split the difference. So in his head, there was some weird correlation between kidney function and the amount of melanin in your skin, and that it was actually continuous. It was not just bimodal. It's an interesting model. I'm sure he was a very good doctor. I'd be surprised if many other doctors did not, in the back of their head, have the very same model. So I think this actually might come to Dr. Enanya's original point, which is even if the math is transparent, the justification is not.
Yeah, and there's, what we call border cases or edge cases are so many cases, right? So how this is, where these, as I think Zach, you said earlier, these...
Wait, I'm Zach and you're Professor? Great.
You're Professor Chair Kohane. As Chair Kohane said earlier, how the box is a bad box and how it's a problematic box runs into these problems when we use it in practice so often. So you should have seen my mom's face. Zach is referring, Professor Kohane is referring to in reaction. She just she couldn't believe that this was the precision medicine approach approach to accounting for her identity in practice. And so, we have to do better.
Dr. Powe, do you wish to remain silent or do you want to make a comment?
No, I will comment on this. Race is a fuzzy concept. It is a fuzzy concept. But however fuzzy it was, it seems to predict serum creatinine for African Americans. Why is that? We don't have a clue. Some people say, well, let's substitute ancestry for it, a biological variable. And actually, there have been a couple studies that show that the percent of African ancestry, the more African ancestry you have, the higher your serum creatinine levels. And those have been done on some very good data on diverse populations. And so you might say, well, gosh, that's biologic. I actually don't agree that it might be biologic because ancestry and race, they're correlated.
That's right.
And they're embodying some of the same concepts, whether it's social or whether it's biological. I don't know the reason for that. As Dr. Ananya said, we have a diversity of people in the United States. There are a growing number of people who are 50%, 50%. If you look, though, from 23andMe data, it's roughly about 75 to 80% of African Americans African Americans have 75 to 80% African ancestry. And then they have other ancestry that is mixed. That's kind of the average across the United States. It varies considerably. Out here on the West Coast, there's much more admixture than there are, for example, in the Eastern United States or Southeastern United States. I will say this, and I love to use this as a personal example. People wanted me to get my ancestry looked at. My kids asked me, Dad, have you done, 23andMe? And I resisted it until I had a colleague who actually sent me a kit and said, Neil, you've got to do it. I said, I don't need to do it. I know what my ancestry is. And I know that because of what my grandparents and my great-grandparents told me. And lo and behold, I did it. And yeah, I am of West African ancestry, and I have some Northern European ancestry. You all know why that occurred. But I didn't need a fancy genetic test to tell me that. So I guess what I'm getting at, we have a lot of fuzziness around all these concepts that we're talking about, whether it's race, whether it's ancestry, but that is the progression of science, to understand how we put all these things together. The use of race back to incorporate into clinical algorithms for EGFR was an attempt to have more precision. It was precision medicine. Somebody found a variable that helped you get to the truth more. Now we come back, 20 years later and we say, oh, it's not socially acceptable to do that in hindsight. But it was an attempt, and I'm sure we'll have this dilemma played out in the future. And that's why the question that was just asked is really a really good question of going forward, particularly people who work in the area of computational sciences, of genetics, to try to, figure out what's going to be their place in developing the science in this area.
Thank you. And let me just say that listening to all three of you makes my real reaction, my internal dialogue is, I wish I could put this in a can and expose every medical school class to this discussion. It's among the most sophisticated discussions I've had the pleasure to witness, certainly about race, but also broadly about precision medicine and about the challenges that we have. It's just wonderful. It's really, I think, foreshadows, as Neil, as he pointed out, a lot of our future. And I'm going to have to figure out maybe how I can steal this video for a future class because absolutely outstanding. We are running late. I'm going to ask medical student Diao to pick one question from the audience. One question. Sorry, not from the audience. I'm sorry. I just want to give the audience one shout out. So, Dr. Future Diao, could you please? Dr. Diao is one of our MD PhDs who has actually co-written with Professor Manrai several of the papers you heard about, but he's now going to channel at least one audience question.
Hi, so just very quick correction. I'm an MD student, no PhD on the list, but I have a question from an audience member who did not give their full name, so ERC, for Dr. Ananya, about the divide between medical and social science. The question is, for a patient perspective, what can we do to help bridge this critical gap?
So that's
in 3 words or less.
Great question. So, I think as Dr. Powe said, things are evolving, and bringing awareness, I think, is step one that we have to learn from the past and that we have to do better, right? This is not something that's going to be a lifetime movie that's just interesting. As we heard from Dr. Akintobi earlier, what are we going to do with the research? How are we going to improve our tools? And I think that using metrics like area deprivation index that looks at socioeconomic and neighborhood disadvantage is extremely popular, right? It was developed a few decades ago by the Centers of Medicare and Medicaid, and has 17 variables in that index that account for socioeconomic advantage, like mortgage or property value, how many people in the household or how many rooms have more than one person, looking at crowding. That has been correlated greatly with readmission rates, for instance, for patients with heart failure, and a number of other outcomes. So I think, using some of these tools that we know are validated, that are accurate, can help bridge this gap between sociology and medicine, and how we move forward, and really keeping those scholars in mind who have been doing this work, again, for decades, and not keeping it so separate. I've learned so much. I'm not going to be arrogant and say that I knew the answer to this question when I wrote about it, or even when the medical students at HMS approached me in 2017. I've learned such a ton, and I've been open to learning, and I think that's also key.
Great. Well, thank you all for just a wonderful panel. Thank you very much.